Okay, good morning everybody. I'd like to thank the organisers for asking me to talk. Sorry, I can't get the next slide, my slide to move on if you can. Thank you. Thank you. So I'm talking about antimicrobial resistance and water and wastewater. There's some people talking about being prepared for the next pandemic, blissfully unaware we are in the next pandemic. And this is called the silent pandemic, and this is antimicrobial resistance. And if we're going to step up to the challenge of this, and this is immense, this challenge, then we need everybody. This needs a multidisciplinary approach, and we certainly need your expertise in the room to solve this. So what I hope to do over this period of time is to give you some background about AMR, show you how it spreads, certainly within clinical areas, and a lot of the talk actually is coming, we're getting evidence now emerging from pantries and kitchens, but the general principles you can apply to other areas. So this is an antibiotic sensitivity plate, and what would have happened is to make a very dilute suspension of an organism that'll be put on the plate. Those discs are antibiotic discs. You put it in an incubator and two things happen. The organism grows, as you can see there, and the antibiotics diffuse out from the discs. And in fact, that organism is resistant to all of those first-line antibiotics. Although there is a slight circle around, clearing zone around the meropenem, it should be going out beyond the yellow zone. And this is what is known as a CPE. I'll come back to what this is. But this is a highly resistant organism which is threatening, well, we have now got the end of the antibiotic era. And as I said, the prediction for this is it'll cost globally by 2050, the end of the antibiotic era is not 2050, it's now. It will cost $100 trillion and 10 million excess deaths a year, year on year. And that's probably an underestimate. These are large figures, and just to give you a flavor for this, that's the world population, that's $100 trillion. This is about $13,000 per head of population. The economic impact is phenomenal. And in terms of deaths in a year globally, it will take out Northern Ireland, Wales, and Scotland, and in less than 7 years, this will take out everybody living in the British Isles, and this will be going on and on. And 1 in every 1,000 people will die from AMR. This will become the leading cause of death ahead of cancers, heart disease. This is going to be our major risk. And we think of antibiotics being used to treat people with infections. A lot of the modern advances in medicine are made possible because we make people susceptible and we protect them with antibiotics. If you no longer have effective antibiotics, these interventions will either carry a high mortality or, as are being predicted, will no longer be offered because they're not offering any advantage in terms of outcomes. So what we're looking at here is a soldier in probably one of the most successful armies around the world. They're spread everywhere, and this is what's known as a carbapenemase producing Enterobacterales. Carbapenemase is because the carbapenems were the group of antibiotics we've been relying on for over a decade now to protect us, and they're no longer effective. These produce organisms. Enterobacterales is because they live in our human gut. So Sir Alexander Fleming made the discovery of penicillin, and it's less than 100 years ago, 1928, and we've already run out of agents. And we've had antimicrobials for those who were alive before the antibiotic era. Their impact was phenomenal. People used to go into hospital with a minor problem and they wouldn't come out. The impact of antibiotics, unless you've seen what it was like beforehand, is very difficult to comprehend. Unfortunately, we've been using antimicrobials as a sticking plaster, and this goes back to what Emma said. It's a sticking plaster because of the emergence, the built environment. As you said, it was Florence Nightingale who made the link between the built environment and patient ill health. So, and we've had an arms race. So in the 70s, the major organism we were worried about was gentamicin-resistant Klebsiellas. So the pharmaceutical industry fought back with the third-generation cephalosporins. We then saw problems with MRSA and C. difficile, but these are gram-positives. But their masterstroke was this organism, extended-spectrum beta-lactamase-producing organisms. And the pharmaceutical industry responded with the carbapenems. But since 1986, we've had no new class of antibiotics. And now the sticking plaster has fallen off. And what's even worse is the organisms we fear most have taken residence in healthcare facilities across the world where we house the most vulnerable people. And this is identifying poor practices and design, but it's also showing us pathways we'd never realized that organisms spread. And we only pick these up because AMR is easier to track. Sensitive organisms spread, they're like stealth organisms. The resistant organisms don't like the sensitive organisms don't like the resistant organisms because they're giving the game away. And we now have organisms resistant to all antibiotics are now present in English hospitals. So AMR, as I said, it's removed our blindfold. This has shown organisms emerging from wastewater systems and going to patients. And it's not that sensitive organisms don't use this route. They've been using it all this time, but it's gone undetected. Such trigger events to seeing things are not unusual. If you think Pseudomonas was only recognized as spread by water when we had the deaths of 4 neonates in Belfast, and Legionella we only realized when there was that large outbreak in America of Legionnaires attending a conference in Philadelphia. So when we talk about water and wastewater systems, we're now splitting it. It's no longer water. If you've got a water safety group, it should be a water and wastewater safety group. So there's the main body of the water system where Legionella, but the wastewater system, nobody's looked at this for at least 80 years, have been updated. But what we're now talking about is the periphery of the water and the wastewater system. This is the last 2 meters of pipework, any connected device, and the drain to just past the waste trap. And this is where the vast majority of transmission events occur within a hospital. And this is a new emerging discipline, and this needs infection control and clinical teams to actually sort out the risks from this. I'll just show you this because you do get extensions of the water system, and these floor scrubbers and some of the robots out there we've got to be careful with because they have been spreading CPEs, and almost the name's giving it away. Although it's autonomous mobile robot, it's highlighting this is also antimicrobial resistance. So as I said, I'll talk about kitchens and pantries. So if you shut the door on the kitchen and pantry, you may think there's no risk of organisms entering the room. Unfortunately, this is not the case, and the problem doesn't even begin at the ward level, actually within on other floors or even within the hospital. The issues may occur several miles away across the city to where the water treatment plant is. And we're lucky, we have high quality water pumped in underground pipes into our hospitals, but water has a natural microbial flora, and these organisms are known as opportunistic premise plumbing pathogens. They're normally there in such small numbers they don't cause a problem, but when you get into the water systems of a building, if the conditions are right, these can cause issues. So Pseudomonas, Stenotrophomonas, for those of you aware of what happened at Papworth with the non-tuberculous Mycobacterium abscessus, these are all waterborne organisms. So the first life forms in a hospital are going to be water before any patient gets in there. But also entering the hospitals are human beings, patients, visitors, and staff. And depending how you can view it, you can either see that human beings are public transport for microbes or we're Trojan horses. But in the large gut and the large bowel of a human being, there are more bacteria than people on the planet or cells in your body. And if you screen, we screen people for resistant organisms. For a CP, we take a rectal swab. And as I said, this is where these organisms reside. So they're going to be taken by people into the hospitals. And people may come from a variety of places. They come from abroad and bring the bacteria from abroad into your healthcare facility. So if we go back, the problem is often under our feet. And if we look below the floorboards, we'll see the pipes, and we'll see the hot water, cold water pipes, but there's also the wastewater pipes. And what I'm talking about today is preferentially aimed at wastewater systems, although water has got its own risks and its own flora in there, as I said, which can cause problems. So the first area of a hospital really to recognize this risk is the sterile pharmacy area. And this goes back to 1994, a very tragic incident. They had pediatric patients with cancer die, And because they couldn't take in food, they had what's called total parenteral nutrition. So this is intravenous feed. And children receiving the intravenous feed became very unwell, died from septic shock. And what they were able to show was the feed was contaminated. And it was contaminated because they had a sink in the room. It was splashing from the sink drain that got into there and caused the infections. So this is the first area to go water-free. But things have become so bad on some critical care units around the world where they've had outbreaks of multi-drug resistant organisms, and the only way they can get on top of this, because standard infection control precautions are not effective, was to remove water services. And so the first unit was in Holland, and they removed the sinks in the patient's room, and this is why the term water-free care. And not only did they terminate the outbreak of multi-drug resistant organisms, they also had a drop in the sensitive, more susceptible organisms, as you'd expect. And this again shows the susceptible organisms have been using these routes and we've never understood it. So when you look in a city, virtually every building or most rooms will be connected to the sewer system. And if you were aliens and you're small enough and you wanted to invade, nobody see you, the way up into all the buildings is through the wastewater system. What we want to do now is to go into a healthcare facility and look at the wastewater systems. And of course, if you open up the main surge stack, this should come as no surprise when you see what's in the middle of that. And as was said, this is where the most resistant organisms are going to get into the wastewater system. And so the question is, if you've got these 3 patients in geographically distinct areas of the hospital, one of them has got a highly resistant organism, how is it that it can be actually transported to those other areas? And the answer is, could it be, is it from the wastewater system? So how do organisms move around wastewater systems? And this is a wonderful paper, came out of St. George's Hospital in 2012. They had a multi-drug resistant organism popping up all around the hospital. Patients who got an infection with it had an 80% mortality. It took them 4 years to track it down, but it was coming from the wastewater system. And they essentially said the wastewater system was a superhighway for the spread of organisms around a facility. And what they didn't mean was traffic, but they actually meant for microbes, where they could exit from lots of different sites, hand wash stations, drains, showers, anything which was blocked, but we know you don't need to be blocked for organisms to escape. So what actually happens in wastewater systems? If you go to the toilet and you flush the toilet, you'd expect the water and the human waste to go down the surge stack. It does. But something else also happens at the same time. As it's falling, air has to escape. This causes a draft upwards, and this creates an aerosol of water and bacteria which can rise several floors in a building. And in fact, the first outbreak we recognized coming, if you remember the early SARS, this was around the new millennium, this was a virus which was excreted biologically active in the gut. There was a highly immunocompromised person with SARS in one of these large tower blocks excreting the virus. There was an outbreak. This is just showing you the floor plan. So these are all the flats on the same floor. You'd expect perhaps the transmission would occur with people on the same floor because they'd be sharing the lift and things, but it wasn't. It was vertically within the building, and it was through the wastewater system. And this is some work from Professor Gormley up in Scotland. So this is several stories high, representing a surge stack. They've got a tracer organism there in a suspension representing flushing the toilet, and there's a toilet at the top of this. They've just lowered the level of the water there so air can get out. So when they flushed the toilet, what they were able to show was these organisms traveled up the surge stack, and you could isolate them in the air and contact plates. And when you look in a building, it doesn't matter whether it's your kitchen sink, your bathroom sink, your toilet or shower, they're all connected to the wastewater system. Blockages in wastewater systems in a hospital are common, often not collected. People don't collect the data. At St. George's, there are more than 400 a year. Every time you get a blockage, a patient's life is being put at risk. And of course, you can then, sometimes you get wastewater actually coming out. That's clearly a risk, but you don't even need that to happen. And we're pouring antibiotics down there because a lot of the antibiotics we give are excreted biologically active, especially in urine, and it's probably this which is driving AMR, because AMR is nothing more than pollution. We've taken naturally occurring substances which occur in small amounts, industrialized it, and we're now pouring it in there, and Darwinian selection pressures will select out resistant organisms. You might think somebody's come back from a walk and washed their muddy feet, and unfortunately this is not the case, because you see when you flush the toilet and the bath are connected, and there's a blockage distally. This is fecal material coming up into the bath. So we know these organisms can move around the system. What happens if they get into a waste trap of a sink? This was a study from America. They injected a waste trap of one sink there with bacteria, and this was in a gallery of sinks. And within 7 days, it had spread to the other waste traps. This one was actually going up against a gradient, and if you left it longer, it had got into the other waste traps. And there was no obstruction to flow. The purpose of a waste trap is this. It's to have a water seal so you don't have the smell of sewer gases. This is a P trap, and this is another version. This is a bottle trap. Bottle traps are very compartmentalized. It doesn't take much to obstruct them. But this is other work. If you take a clean waste trap, you fill it with bacteria, you then put it into a high-risk scenario, and the high-risk scenario is where you've got a sink where water from an outlet directly hits the sieve above, and you put some agar plates next door, and you look for growth, you won't find any organisms. However, if you repeat the experiment and do one very simple thing, and this is you add a carbon source or a food source, then something quite remarkable happens. Biofilm grows up the vertical section at a rate of 1 millimetre an hour. And this will reach the top of the drain. And if you think what's happening in kitchens, we're pouring we're just feeding it. It's a feeding frenzies going on down there. If you now put this into the sink setup and you run the water so it hits the drain, you will now detect organisms from the wastewater trap can be grown on these agar plates. So I'll just show you what happens in a clinical scenario before we move into kitchens. So this is a high-income country. This is from Canada. This is the ITU. We're walking in through the door there. You can see the sink. You can see the preparation area. They had a highly resistant strain of Pseudomonas. This is the sink in question. They tested the water. The water wasn't positive, but they could find the organism in the drain. So the question was, how was it getting out of the drain? They did a very simple experiment. They put some fluorescein dye into the drain, as shown there. They then shone some UV light to make sure there's no background fluorescence, and then they ran the outlet. And what they could find was dispersal of fluorescein dye at least 1 metre. They couldn't exclude it going further. And if you go into the room, you can see the preparation area there. This could be a food preparation area near a sink, but this is where we're making drugs, procedures. You can see how these organisms now get to patients and infect them. This is just showing, similarly, this is putting fluorescein into a stream of water. The fluorescein is under no pressure. It's just going in there. This is time-lapse photography, and what you can see there's the green dots. Some of these splashes there are, I don't know if you can see it, they're so large they run down, but they can travel up to 2 meters. So when you're looking at any sink, it's not whether it's a clinical hand wash station, anything, in essence, you're looking at a rocket launcher. This is capable of launching either water organisms or wastewater organisms, if the conditions are right, into the environment. This is from CDC in America, just showing some of the risks they're identifying. And as I said, kitchens and pantries and other areas are just coming up. We certainly recognize food preparation for babies in these areas, outbreaks, these get back to these areas, but anything where you've got a sink is potentially a problem. But it's quite amazing, even in some ITUs, they've been storing, people don't realize it, storing clean products around a toilet facility. But if you go into the cleaners cupboards and things, you're pouring things, often filling buckets, you think of the storage of clean items within the splash zone. They all need to be taken away from these areas. So I think what's key is terminology. And I think some people say, should we actually be using the term cleaner? Because it detracts from what's actually going on. Because a cleaner really should be a decontamination expert. And again, when we think of rooms, we need to think of what's going on in a room. Is this a clean or a dirty mixture? What are the assets being used for? Are there routes back to the patient? And if there are routes back to the patient, is the microbiological quality of what's going back to the patient safe? So this is a drug preparation area. But the term's wrong. It's not just a drug preparation area, because you see this is a mixing of clean and dirty. These are the drug administration trays. They come back from the ward, so they come in contaminated into a clean environment. There's no flow from dirty to clean because we don't design it like this. So you may have the tray. You can see these wipes for decontaminating. These are alcohol wipes, probably going to be ineffective because somebody's left the top off. And even if you did clean it, you're putting it back down on a surface which may be contaminated. So we've got dirty and clean in the same room, and we're not acknowledging it's a decontamination area. And here you can see in this pharmacy area, they're decontaminating water. This doesn't look clean, and you can see how now we can get organisms with your drugs going back to the patient and causing infections. And I'll just show you this. A lot of the things which go on at ward level, so if you look at ward-based decontamination of medical equipment, it does not follow good infection control practices. It does not follow good decontamination principles. But people are put up with it on the basis that where's the evidence? But that's on the assumption when we say where's the evidence that our surveillance is 100% sensitivity. Our surveillance does not have 100% sensitivity. For a lot of these things, it's extremely poor. As AMR is showing us, sensitive organisms have been getting away with it all these years, and it's only AMR which we can track. So this is we're looking at decontamination of medical equipment at ward level. Just putting 3 hours extra in a day, they had a 35% reduction in healthcare associated infection. So just because we don't think there's a problem doesn't mean there isn't a problem. And it's not surprising. Ward staff are not adequately trained. They don't have the time. It's a chemical method. There's no audit. There's no segregation of dirty and clean. So this is phenomenal. What are we going to do with it in the NHS? I don't know who's going to address this. So if you talk about a pantry and a kitchen, the terminology, the name, doesn't really convey what this is. This essentially is a decontamination unit. It's a mixture of dirty and clean within the same room. So you're decontaminating items, but you're also bringing things back from the patient's room, some of them being in isolation. So the sources of organisms include, as we've already seen, the water and wastewater, and outside the room, items returning from patient rooms. And we need to have a segregation for dirty and clean. So is there any evidence about what's going on in these areas? And well, this evidence is emerging, but I would say it's the tip of the iceberg. So this is some lovely work done in Leeds. All of those items there, the jug, the coffee, the water dispenser, the tray, all of them were found to have carbapenemase producing organisms. And also on the draining board underneath the hot water geyser, they had carbapenemase producing organisms. If a patient gets infected with one of these, even if we have 1 or 2 effective antibiotics left, the mortality already jumps up, because most people, if they become very unwell, your best guess antibiotic needs to be effective to actually deal with the organism. Overall, people with organisms in their bloodstream, 80% are on effective therapy. If you have a CPE in your blood culture, 80% of people are on ineffective initial empirical therapy, so their mortality goes up. And they conclude, by saying ward pantries, kitchens provide reservoirs for CPE, especially in water and wastewater pathways. Improved processes for food and drink delivery, trolley return, cleaning practices, and education of catering staff is an important aspect of CPE outbreak control. But to control it, it needs a multidisciplinary approach. It's not just infection control, it's the people working in there and all the people who feed in there. That's the only way to come up with the best solutions. Here's another one talking about it, and again, finding they have an outbreak on the ward, difficult to control, and they're finding things going on, trays positive in the zonal kitchens as well as the pantries. And here's another one, and their conclusion, this is the first CPE outbreak. This was going back to 2000, highlighting the role of a ward kitchen as a possible source of cross-transmission. In view of this, we suggest ward kitchens are reviewed and investigated. So we were talking about interesting, your talk before, I go around and often visit areas. This is a dishwasher. As you can see, it broke down on the 23rd of December. I visited on the 16th of February. This hasn't been replaced. And nobody sees this as important. But this is a decontamination area. This is your main thing. And actually, just to go back, I don't know if you saw in the inquiry in Glasgow, part of the problem with the dishwashers is people were getting the tubes which go into the rinse aid and detergent mixed up. So rinse aid was going in when detergent should be and vice versa. So there's lots of things to look at. And when it's not working, we need to have, there should be a spare there. So if it's not fixed the same day, it is being repaired if we value patient safety. And what should be the front and center of everything we do is the patient. And that's the cheapest way of actually delivering healthcare, because people get infections, they're going to be longer in hospital, we're using antibiotics. This is another kitchen, pantry ward. This sink is CPE positive. And if you look underneath, you can see the waste trap and the toaster. That's a leaking waste trap, and the ward toaster's getting, I don't know whether people want some jam or butter on their toast, but they're getting, I don't know what CPEs taste like, but they're getting a dose of that. Here you can see, look at this. I mean, we often, pantries are a bit like dirty utilities. Whatever the architects get left over, we'll just push in there. We don't think of flow. We've got to start changing this. Really, can you expect things to be safe in an environment like this? This is the lovely work they've done at Leeds, but that was achieved by multidisciplinary working, getting people in there, working with infection control, everybody, to work out what the problems are. As we said, these food trays come back from patients' room. These can be a source. And when they come back, what should we do? Should we have extra dishwashers so when it comes back, it goes straight into the dishwasher? But we need to segregate dirty and clean if we're going to get on top of these. In Manchester Hospital, which has been a source of CPEs, in fact, to say this was the first outbreak linked to kitchens, I think it was incorrect, the people back there. So they had an ongoing CPE outbreak on their cardiothoracic ward. They eventually traced the source of this back to the ward kitchen. And what they think was the route of transmission is when people fill the jugs, they rest them on the drain, and this picks up the wastewater organism and then takes it to the patient. They took patients out of the ward, replumbed the kitchen. When they went to another ward, the outbreak stopped, suggesting this is a built environment. Came back, they were in a honeymoon period, and of course the organisms eventually come back from the wastewater system, get in there, and got back to the patients. It's interesting, if you go to food preparation areas, it's a hands-free approach. On pantries, it's hard to understand. Here's a tap, this is in a pantry. If your hands are contaminated, you're going to turn the tap on, you're going to wash your hands and recontaminate them. But the same thing happens in toilets. If we believe, you need to rinse these organisms off your hands in a toilet, why do you have something which is hand-operated? So hierarchical task analysis, this is something which I was taught in the new hospital program, and I find it very useful because this really, I think, shows up the risks. This is a kitchen. This is for transplant patients, and they've decided in here that they're going to they want high quality water, so they've put a point of use filter sitting right in the main bit of the kitchen, and that was it. But hierarchical task analysis, you'd look at the whole pathway and you'd start seeing the risks. So you can see risks here. There's the high pressure jet hoses. If you just open the dishwasher, you can already recontaminate it. But this is a pantry, hands operated. But from the point of use filter, this is going to get covered in water or splashing, and the water coming out will pick up these organisms. So this, fine, it's good, you want that standard of water, but if you don't view the whole pathway, you won't understand what's going on. Again, this is another hematology unit. You're using boiled cooled water, but you can see it's on the draining board. There's going to be splashes from the sinks, and you can see there's clearly a problem with drainage here because they're having one of those pumps to try and unblock the drains. So what we're talking about here is you walk the pathway and you ask the right questions. So first of all, what are you trying to do? What you're trying to do is deliver safe water in a jug which is not contaminated. There's no point in having safe water if you're taking a CPE into the room on the jug. So again, it's asking the right questions. This is what you're trying to achieve. And when you walk the pathway, you'll start thinking of, well, how are you going to decontaminate the jug? Is your dishwasher working? If it comes out and your jug's not dry, you don't want to put it on the draining board. How are you going to fill it? And I'll show you how you fill it. You've got to transport it to the patient safely. People need to know you don't want the relative refilling it at a sink in the room. People need to understand the whole process. And using a hierarchical task analysis, if you can see the risks, you've got a chance of mitigating them. If you can't see the risks, just putting a point of use filter in, you're not going to see the risks. This is a very nice system they developed at Leeds. So you don't, they've got the filters there, but you don't have the drain there. This goes through a dishwasher every day, so they've removed the risk of actually taking CPEs from a drain or other wastewater organisms to the patient. And also, you've got to think about when you go into the patient room. Often in the lobby, somebody who's in isolation for a reason, often protective, where are you going to put the jug if you're going to wash your hands? You're going to put it on the sink, or brilliant, you'll put it on the thing. And in fact, you see drugs going in there, somebody going, they rest them there. Nobody's thought through the process. And of course, what you need to do is you need to have a shelf in and out of the room, one for dirty and clean. So again, we're segregated, and you can get it into the room. So you'll be glad to know we're virtually at the end now. This was an outbreak in Germany, and they had their own resident CPE. It used to pop up once or twice a month, as you can see there, and suddenly it went berserk. They did a very good case-controlled study, and what they were able to show was this was linked to eating salads. They tested the salads coming into the hospital. The salads were free of CPEs. And what they found was that where it was getting is the salads were left out near a sink, and there was either splashing from the sink drain, this was getting the contamination in the kitchen, or the other thing they found in kitchens is this high pressure jet hosing. You have in-floor drainage, and then you're doing that. So, you know, anybody going near a sink, clean it. You think of what you're doing with your cloths. We've got to, and you know, it's very difficult if somebody gets an infection from that to be able to track it back. And really, you know, everybody, when they come to work, there's only one reason to coming to work, is to protect patients, and you need to know where your role is in protecting patients. If you don't understand that, there's something wrong in the system. And they need to know, everybody needs to know the consequence of their actions. And actually going back to the last thing, so that the kitchen was actually in a separate building. And they were wondering, well, how did the hospital strain get into the kitchen? And they think it was via this. That had a blockage of the drain in the kitchen. That was a coil which had gone down the main sewage stack in the hospital, went down the kitchen drain, and when they tested that, it was positive for CPE. So, you know, what we may have in the future is this. It's giving a very unusual form of food poisoning, but it's not funny now. The things have changed. Well, it never was funny, because when you've got no antibiotics to protect the patient from these organisms, this, in essence, is a death sentence. Thank you very much.